this speaker?
I don't know. Is this loud enough? Can you hear me okay, everybody in the back? I don't know because they can't hear me. So I work for the New York State Department of Health as one of the attorneys. And I don't know why all of you are here. Maybe some of you just have birthdays in June. You need your CLE credits. Or some of you might be experts in this stuff and you already know what we're talking about. Some of you might not really understand what we're talking about. So I'll just point you to some information, and then when we have the panel, you can ask whatever questions you have or raise whatever issues you have based on what your practice is. So for starters, in this booklet, on page 35, there's some guidance that the Medicaid program put out for people doing DSRIP. And that guidance explains our view about what the law is regarding information sharing, and then there's a bunch of references in there. So that's a good introduction to DSRIP, if you don't already know what DSRIP is and what it's all about. And then my slides start on page 48, and they're also up here. So I'm just going to give you a big overview, and I don't know if you're interested in the things that are on these slides, or if you have other things you're interested in. You can bring up whatever you're bringing to this. So my first slide here is just to say that we at the New York State Department of Health have various data systems. So the Medicaid program has all of the Medicaid claims data, and that's one of the things that's being made available to PPSs in order for the PPSs to do these DSRIP projects. We're also a public health agency, so we have all kinds of public health data. We know who has contagious diseases, and more specifically who has STDs, and more specifically who has HIV. So there's all kinds of reporting, from contagious diseases to cancer reporting to cardiac data to all kinds of things, right? And we've been collecting that forever. The last bullet here is that actually there no longer is a Health Information Technology Transformation Office at the Department of Health. What we now have is something called the Office of Quality and Patient Safety, OQPS. And what that is so the Department of Health is vast. We have public health programs, like I already talked about. We also have the Medicaid program, which is a huge public health plan. And the Office of Quality and Patient Safety does some things working with hospitals to improve quality, like getting them to implement sepsis protocols. But it's also a big holder of data from the Medicaid program, from the public health programs, and it's sort of our big data office within the Department of Health. Within OQPS, we're now building something called the All-Payer Database, the APD. And so that's going to have Medicaid data and also Medicare data, which you can buy. It has something that we've had since 1979, which is claims data that come to us from Article 28 healthcare facilities. So in other words, the hospitals submit claims to all of the different payers. And since way before HIPAA, we've had hospitals submit claims data to us in the same format as Medicare takes claims data. Now it's all standardized under HIPAA, so HIPAA claims data comes to us from Article 28 facilities. But what we're building now is the all-payer database, which would not just be the claims data submitted by Article 28 healthcare facilities, it would actually be the real claims data from Medicaid, from the New York State has the New York State of Health, which is our Affordable Care Act implementation. So they have qualified health plans and essential plans that's Obamacare. So we have claims data from that. And then eventually the all-payer database will include commercial health plan claims data. And so the Office of Quality and Patient Safety is our big data hub that's going to be building this all-payer database. So could you go to the next slide? Yeah. So I was just talking about the data that we have at the Department of Health. Now there's also data out there in New York State, which we may regulate to some extent, but it's not our data. So we've already been talking about the DSRIP program, which created these PPSs. And so the PPS leads are a source of data, and that's the first bullet point. And you've probably also by now heard of the SHINE, the Statewide Health Information Network for New York. And that's made up of 8 regional health information organizations, which under our regulations are now called qualified entities. And then there's also the New York eHealth Collaborative, which knits them all together into a statewide health information network. So they're exchanging clinical information, and that's for the purpose of, or the primary and first use case is for the purpose of healthcare providers to get access to data from other healthcare providers of the patient that's in front of them in order to provide better treatment. So just, again, I'm not sure what the background is of the people in this room, but just to give you an example of the difference between claims data and clinical data. Claims data is the claims that you've made. So, for example, it would say that you've ordered a clinical laboratory test, but you don't know what the clinical laboratory test results are from the claims data. Claims data would tell you that a prescription has been filled, which is something that a medical record of a doctor wouldn't necessarily tell you. Okay, so clinical data, the opposite. Clinical data would tell you a clinical laboratory test result because the doctor would put that test result into the medical record. Clinical data would tell you that a doctor ordered or prescribed a prescription, but wouldn't necessarily tell you whether the patient filled the prescription, right? So there's a difference between medical records and claims data. And when you put them together, you have a much richer data set that can be used for population health and for other purposes. Okay, so the third slide. So I already talked about this. This is the all-payer database that we're building. You should probably think of this as a work in progress because that's what it is. The all-payer database doesn't really exist yet in its fully formed form that it will someday exist. We have a regulation, we have a law, we're creating it. Okay, so the last slide. So I'm just going to give you like a use case from my perspective as a public health lawyer of how we're doing big data. Okay, so you've got the Medicaid claims data, which is going to the PPSs, and then the PPS leads are coordinating all of the PPS partners in the PPS, and they have the ability to share information. That's on the left side of the slide. On the right side, there's the HIV registry. So ever since the AIDS epidemic began in the late 1980s, we've been collecting all of the clinical laboratory test results of people who are HIV positive, the HIV positive diagnoses, and then subsequently all of the HIV testing, which is like the CD4 counts, which will tell you if you are immunosuppressed and you're not going to get AIDS, hopefully, or if you are getting to the stage where you're actually going to develop AIDS. So compared to the late 1980s, things have totally changed in the AIDS world. At first, we were just collecting information for the purpose of epidemiology to understand the AIDS epidemic. But now there is treatment, and we are expecting to end the AIDS epidemic by 2020. And so how are we going to do that? We have information coming into the HIV registry, And the name of the game now is to figure out all the people who are HIV positive but are not getting treatment. Either they have never gotten treatment for their HIV positive diagnosis and they need to be linked to care, or they got some treatment but now they're not being compliant with taking their medications, and so they need to be retained in care. So we now have authority not to just do epidemiology, but actually to use the information in the HIV registry to find people who are HIV positive who need to be linked to care or need to be retained in care, so that we can make sure that they're actually getting treatment and they're immunosuppressed and they won't get AIDS themselves and they won't be able to communicate the disease to others. And that's how we're going to end the AIDS epidemic. So the HIV registry is now, or the AIDS Institute in general, is now, developing methods to use the SHINY and to use these different data systems to be able to find the people who are HIV positive, and if somebody shows up in a healthcare provider's office who has high CD4 counts, meaning they're not immunosuppressed, that provider could immediately get an alert, ding, 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 hey, this person has HIV positive, you need to make sure they get treatment so that they don't get AIDS. And so that's the kind of thing that we're working on right now.
The MCLE verification code for this program segment is 723.